Welcome to our presentation on feeding and eating disorders. I'm LeAnna Armstrong, and my group member is Melanie Rivers, and we're going to be going over anorexia, bulimia, and binge eating disorder. And per Professor Mallory's request, we're going to briefly touch on pica. Throughout the presentation, I'm going to be referring to my past experience on working in eating disorder treatment facilities also.
So what is an eating disorder? An eating disorder, they are illnesses where a person exhibits a variety of unhealthy eating habits. The consequences of these eating habits are mental, emotional, behavioral, and physical consequences. They also have issues with control, where they want to control what is actually going into their body, and they also may have a lack of control to where they cannot stop eating. They have an obsession towards their body, and they also can have food cravings. What is anorexia nervosa? Anorexia is uncharacteristic low body weight. They can have an extreme fear of gaining weight. They can also have a distorted perception of their weight. They have limited food intake. They also have problems with body image, and they are at a high suicide risk.
So we found that anorexia actually has the highest rate of any psychological disorder. It poses many serious health risks, and there are comorbid disorders such as anxiety, disorders, bipolar, and depression. In the picture on the right, my 13-year-old daughter actually brought this girl to my attention before I took this class. This is Eugenia Cooney. She's a 24-year-old YouTube social media star, and she has anorexia, and she has 1 million subscribers, mostly young girls who look up to her and idolize her. And actually, before we started this presentation, I saw in the news where she recently sought treatment. So hopefully her viewers will also follow in that path.
Next, what is bulimia nervosa? So bulimia is when people have episodes of eating a large amount of food in a very short period of time. So this large amount of food could be something like a large pizza, where they don't just eat one or two slices and then put the rest away and then they come back and eat some later. They'll eat that entire pizza in one setting. They do have a feeling of being out of control where they can't stop eating. Um, these binges will be followed by a compulsion to compensate for their behavior of their binging. They will do this by purging. They'll take medication that will induce vomiting. They also may take laxatives or diuretics, and they could also do extensive exercising, where they may decide to go out and run or do long periods of exercising in the gym to compensate for their binging behavior.
There's a high crossover rate between anorexia and bulimia. You can see also in the bottom picture on the slide, this is a picture of the mouth of someone who has bulimia, and there's damage to the roof of their mouth and their teeth. The enamel on their teeth has actually eroded from the acidity in their stomach when they purge. Oftentimes, in the treatment center I worked at, we would see clients come in and we would know that they have bulimia because they would have calluses or scars on their knuckles from where they stuck their fingers down their throats to actually purge.
Next is binge eating disorder. So what is binge eating disorder? Binge eating disorder is where a person consumes a very large quantity of food over a short period of time. So again, this can be as with bulimia, where they may consume an entire pizza. They may consume a cake by themselves or a pie by themselves, and they'll do this in one setting. They will be in emotional and mental distress. So they may have feelings of being very guilty for overeating the way that they did. These episodes can be repeated um, continually. So they may do binge once a week, and over time, this may increase to once a day or twice a day. And as these episodes increase, so does their the severity of their binge eating disorder. And they also, unlike with bulimia, they will not have any purging behaviors or do anything to try to compensate for binge eating. So they will not purge, they will not use exercise to compensate, they will not take laxatives or diuretics.
So some things that happened in my experience in working with people with binge eating disorder, it was very common for other clients in the program for their food to go missing. Um, People with binge eating disorder, they would actually run out of their food very quickly and begin to steal others' food. And we would commonly find like food, like a lot of food in wrappers under their beds. They would actually hoard food and then try to hide it. So the diagnostic criteria. So for anorexia, there's actually two types. There's the restricting type and binge eating and purging type. And that's kind of where the crossover comes in between anorexia and bulimia. So three criteria have to be met for at least 3 months to be diagnosed as anorexic. The first is the restriction of energy intake resulting in low body weight, which is like, restriction of food, caloric intake basically, which puts a person under a weight that is normal for their, age, sex, and those kinds of things. There's an intense fear of gaining weight or becoming fat, and behavior that interferes with weight gain. There's a disturbance in the way their bodies experience, and they have a lack of recognition as to the seriousness of their low body weight. For instance, I worked with a client who was under 100 pounds. She looked like a skeleton, and she would often grab the skin on her stomach. She could barely grab any because there was nothing there. And she would say, "Look at this roll. Look how fat I am." And she would point to other clients who were significantly, larger than her and say, "Your body's perfect." So she, didn't experience her body or like she saw it as it wasn't realistic. And the severity of anorexia is based on a person's body mass index.
So, next, the diagnostic criteria for bulimia. There are three essential features um, when diagnosing for bulimia. First, recurrent episodes of binge eating. Next, they are constantly compensating for their behaviors to prevent weight gain. These compensatory behaviors would be through exercising as well as purging or using diuretics or laxatives. And third, self evaluation of their body that's unduly influenced. So they're constantly looking at their body shape and seeing what it is that they do not like about their body. Um, when diagnosing for binge eating, it is also looked at for when they are inappropriately compensating for these behaviors. It must occur at least once per week for at least a period of 3 months. And the level of severity and frequency of this behavior, of the compensatory behaviors. There is a normal or overweight range, in normal or overweight range, I'm sorry, and this is uncommon among obese people.
In binge eating disorder, there are recurrent episodes of eating, like in a discrete period of time. The amount of food is like larger than a normal person would take. There's a lack of control over eating during the episode. So the episodes are associated. There has to be 3 or more of eating faster than normal until they feel uncomfortably full, eating large amounts when they're not hungry, eating alone, and feeling embarrassed about it or disgusted, depressed, or guilty is very common. And for a diagnosis, like a recurrent episode of binge eating must occur at least once a week for 3 months. And again, binge eating disorder is different from bulimia in that people with binge eating disorder don't purge or after they binge or take laxatives or something like that. So now we have etiology and neurobiology. We found that anorexia, bulimia, and binge eating disorder are actually very similar in these areas. There's like a heredity component. There's an increased risk if someone has a first-degree relative with an eating disorder. There's an increased risk if the mother has pregnancy complications. And of course, there's societal pressure that in the culture we live in today basically says, men and women's bodies are supposed to look a certain way, and this is amplified by, media, marketing, and social media. And what we found interesting is there's altered brain serotonin function in all of the eating disorders that contribute to the deregulation of like appetite, mood, or impulse control. It was interesting in anorexia, it was different in the reward pathway in that the restriction of food reduces their anxiety and actually releases dopamine. Whereas with bulimia and binge eating disorder, the binging, excuse me, there's an abnormal increase in dopamine during a binge, and the same with bulimia. So, and in the picture on the bottom of the slide, they found that bulimic patients had a greater response than anorexic patients whenever they were showed images of food. And you can see on the right, the bulimic patient's brain just really lit up when they saw an image of food, and dopamine was released. And then on the left side is the anorexic patient who the brain didn't light up as much as the bulimic persons did.
So the prevalence of anorexia, bulimia, and binge eating disorder. So the prevalence with anorexia, it is more common in females, and there is a 12-month prevalence in females of about 0.4%. And it is more common in those with a mental illness already. With bulimia, it is also more common in females. It's also more common in young adult females. There is a 12-month prevalence in females that is about 1 to 1.5% of females. And it is also more common in those with mental illness. With binge eating disorder is the most common disorder in the United States. It was added to the DSM in the most current DSM-5. And one of the reasons why was because people needed to get treatment for binge eating disorder, and you have to have insurance to fund it so that you don't pay for it out of pocket. It is more common in females. The 12-month prevalence in females is 1.6%. And it is more common in those with a mental illness. And it's more common among people who are seeking weight loss treatment.
So these eating disorders, they affect people of every age, sex, gender, race, socioeconomic status. The problem is people, there's a common belief that, white upper class females, they're the only ones who have eating disorders, but that's not the case. The only reason that it's seen like that is because these people have more access to treatment. Additionally, it's also minimized that men have eating disorders. And that goes along with our cultural stigma. There's actually 25% of men have an eating disorder. And we also have to consider, cultural considerations. And, for example, in the treatment center I worked in, clients wanted to fast for different religious holidays, and we had to respect that out of fear of not wanting to be sued, but it did interfere with their treatment. And as far as treatment interventions go, there is no one medication that fixes all of these disorders, and there's no one medication that is made to treat an eating disorder that's approved by the FDA. They found that components of all these things that are listed together, that's the strongest treatment intervention. So, the person getting medical attention if it's needed, inpatient or outpatient treatment, therapy, especially cognitive behavioral therapy, is seen to really help people with eating disorders. A psychiatrist, nutritionist, a common medication used for anorexia is Zyprexa and Prozac to help with obsessive thinking, weight gain, and weight management. In bulimia, the only medication approved by the FDA for bulimia is Prozac, which is an antidepressant, and in binge eating disorder, the only thing approved by the FDA is Vyvanse, which is a stimulant. And they found that the chances for recovery increases the earlier an eating disorder is detected. So there's a lot of hope for these young people.
So, lastly, we're going to talk about pica real quick. Pica is the persistent eating over a period of at least 1 month of substances that are not food and do not provide any type of nutritional value. With pica, there is the ingestion of substances is not part of a culturally supported or socially normative practice. It typically, substances ingested tend to vary with age and availability. They may include paper, soap, cloth, hair, string, and it is important to know about developmentally appropriateness and inappropriateness. In children under 2 years of age, putting objects into their mouth is common and is a normal part of their development.
Okay, and here are our references, and if you have any questions, please contact us with these emails.